the opportunities at Piedmont that directed us and connected us with surgical directions was a evolving and changing anesthesia landscape. We have a very large system, about 17 acute care hospitals, and we had 9 different anesthesia provider groups supporting our hospitals, from an employee group to community groups to groups that are now national size groups that are primarily private equity backed. And over the last few years, we saw that our hospitals that were covered by groups that were primarily backed by private equity were in a position where they were being asked to pay more and more for services, and those services were not performing at the level that we expected in many cases or in some cases, but also the threat of disruption to our surgical services footprint by contract negotiation, potential threats of termination of our contracts really forced us as a system to ask ourselves, well, why aren't we doing this ourselves in order to minimize the potential impact of one of our key profitable service lines, and also to ensure that we have procedural and operational continuity throughout the system. So we were able to connect with surgical directions, great expertise in the space, and we early on knew it was people that we should work with, and we engaged, what now, Jason, maybe about 2 years or so ago?
About 2 years, yep.
Yeah.
This winter. Yeah, and Steve, you know, I thought, and you said it so well, but really, your main question that you had in the leadership there at Piedmont was, you know, where are some gaps in our anesthesia service? A lot of questions about value. We have escalating costs, and we don't feel like we're getting the value from that service. Bottlenecking of procedural care at multiple of your centers. And then really, I think a big part of the project was not only those questions and validations of is employment right for us, but also doing a high level inventory and gap analysis of some of your other practices as well, whether it be a national vendor or a small local community, and then comparing and contrast that with some employed services you already have.
I agree 100%. And I think too, with that is how we brought operational performance of our hospitals into the equation as well, because our cost of anesthesia may have also been increasing due to poor performance or opportunities to improve the performance of our operational services. We always said from day one, Jason, that you can't optimize anesthesia without optimized operations. So how do we bring the two together?
Right. And I think a big part of our work early on, when we had this question of what would the financials and care of our patients look like if we were to transition to other services, was a big part of that, taking into account your surgical volume at various places, communicating you and other leadership where you were, where it was normal, what was below normal, what was, doing very well in that space. I think another big part that we looked at early on was some of the variable contracts you had, and you had different vendors. But even with employed sites, there were contracts and some legacy contracts that we found some opportunities for financial and alignment improvement with the providers in those groups.
Yeah, I think you're completely correct. I mean, if you think about it, even on our employed side, those sites became employed out of necessity. Either the groups were unstable or we acquired an employee group through merger or acquisition. And there was no consistent process for how do we pay physicians, how do we pay anesthetists, and what are the expected needs from a coverage model perspective. It was piecemeal, and we were working closely together to standardize as much as we could across the system.
Right. I mean, I know one location early on, the physicians and the providers practicing there, they really weren't giving you the value as far as what their call schedule was. And, looking back at the contract, talking with you all about best practice, amending some of that was really something I thought was important early on, to look at the locums cost mitigation strategy that you all had. And, finding out and doing that initial inventory of where you stood at all of your practices, I think was a really key first component of this, to see where you wanted to go after several months of looking at this. So what is the strategy, goals, and tactics we're going to use to get there?
Very much so.
looking back and almost 2 years ago, we kind of sorted it as to where were the best opportunities to improve patient care and financial situations, right? So first and foremost, it was a long, hard look at the vendor-backed staffing companies that were involved in some of their larger hospitals, looking at where the options would be to part ways with that group. What would it look like on the other side? What would other vendors or employment look like, and doing a lot of the dirty work there to find out what that situation actually looked like in reality. I think another big part that we looked at earlier, like we just spoke about, was a lot of the contracting. But I think one big thing also was trying to bring in, and some of the earlier work we did for standardizing some of the ways that anesthesia is practiced within Piedmont. There were a lot of silos, and everybody was speaking the same language, but it was a little bit of the different dialect. How PTO was done, how schedules were done, how we do staffing ratios, what is the scope of practice for CRNAs. And while we worked on the immediate need of making sure that they had the best relationship with a vendor or employment, we started working in some of those things about a larger picture, a longer strategy as far as aligning anesthesia services with best practice and procedural care operations.
Yeah, Jason, I don't disagree. I think too, what we did is we had to become educators. The hospital operators themselves really, were running operations, but they didn't understand the role anesthesia can play in that, the cost of what is the cost of running OR? What's the cost of running OR if you're only utilizing it 50% or 40%? How we need to bring in, it's not just an OR issue, it's a procedural issue. It's anywhere in the hospital that is supported by anesthesia, and the roles that they can play, the type of care models they were demanding when, hey, you don't really need a physician for this piece. It'd probably be better to use an anesthetist in this area. So looking at that was incredible. But also, as we were trying to figure out options, we went through kind of a prisoner's dilemma process. Everything, is there a way to change the relationship with the current vendor to be more aligned with the facility or the system's needs? Is there a different partner out there that we could bring in and actually look at maybe creating a joint venture model? We talked to one or two companies out there. And three, do we really understand what it means to take on an employed model? When we talk about an employed model, we're talking about possibly building a group of 600 providers.
Right.
And that would make us one of the largest anesthesia groups in the US. And are we able to do that? So that was the more long-term vision. Do we need to take interim steps through A, B, and C to get to that? Or do we I think we had a very open, direct conversation about, do we just go ahead and pull the Band-Aid off now and just do it, which is what we ended up doing.
Yeah, and I think along that path, we also talked a little about MSO or managed services, options there. And, are there groups out there that can help us manage? Because one big part of this was leadership and organizational structure, and making sure the infrastructure was there to carry this out successfully. What are we going to do about chiefs here, right? What are we going to do for scheduling? What are we going to do with payroll? All of these things to make sure we had everything lined, that we eventually were able to say, Steve, Piedmont, I think we can pull this off successfully. And those were just, again, it was 2 years of work wrapped up into this short podcast, but those were big parts. I think leadership and finding the right leadership was also really key for the long-term sustainability of this. And thankfully, you guys found one. It's proving to be pretty challenging out there in the world of anesthesia. And then, the other thing that came to mind was the revenue cycle. I think that was a big factor in, bringing that in-house, maybe finding the right partner. What is that improved performance of, revenue cycle, and how can that offset some of the costs that we may incur for this transition?
Yeah, that tied in part of the standardization as well. We had 3 different anesthesia revenue cycle companies covering a small footprint, and how do we consolidate down to 1 or 2 in order to drive revenue cycle performance, and which has been fairly dramatic for us in many ways in terms of the better performance goals that we have met. So
I just want to chime in. I think another thing came to mind that was really crucial to the success we had, especially with the three sites that were run by a large national vendor. Steve and Piedmont, you all made a huge investment for some of the legal restrictive covenants to allow those providers to stay at Piedmont, which was from the start one of the most important things you all wanted and pointed out.
Yes.
A retention strategy to make sure that that investment wasn't wasted was a huge part of the work we did. And ultimately, I believe one of the most important things to the success of this transition, and frankly, for how Piedmont is perceived in the market. Not everybody decides to pay out these restrictive covenants, really go after and retain in an aggressive manner the providers that are there, that have been caring for their community, have been at their hospitals and know the administration, that know the surgeons. And that was a really, really big piece of this and the success that followed.
Well, we were able to retain 98% of the providers, it's really unheard of when you're going through these transitions. So.
Right. And that was with salaries and compensation packages that were at market rates. I mean, we did a lot of work to make sure that the compensation packages were appropriate and would be able to not only retain but recruit. And I think it's a real testament of the fact that, the culture that was there and within Piedmont is a big factor in keeping people in their seats in this really dynamic anesthesia world right now.
I was going to just say that it wasn't the money.
No.
But it was people wanting to remain in the culture that has been developed. And we didn't want that to change either. So it was a big investment, but at the end of the day, we're going to save a fortune because, again, we retained 98% and the cost to replace 50% would have far exceeded what we had to pay for those providers to be able to stay here.
Yeah.
We did have a concern about safety. If we had to bring in 50-60% of the workforce as contractor locum, that always introduces a risk to the environment. It's a new environment. You create more holes in the Swiss cheese where harm could reach the patient. We have a very high quality anesthesia team across all of our hospitals, and the one that we just transitioned over were our top performers in the country in terms of anesthesia quality and safety. So yeah, we did have a concern that if we didn't retain as many as we could have introduced an opportunity for harm to reach the patient. And so that did factor into our decision.
I think the calculus in that decision has changed a little bit over the last maybe 5 or 6 years. The locums pool is different now than it was 5 years ago. And, one of the calculations we had done when we were figuring this out is attrition and locums replacement rates. And where are those thresholds? What does it look like? What does the cost look like? What does it mean to patient care? So those are all very thoughtful factors that we weighed in and talked to Steve and the rest of Piedmont leadership. And then we also had a plan if there was a fair amount of locums, how they were going to be vetted, what companies were going to serve us the best way, and other factors like onboarding that we're trying to make sure that we ensure great patient care.
And I would put on top of that was one of the reasons we had a business reason and a quality and safety reason to create our own internal 1099 locums company. If someone felt they needed to leave because of X, Y, or Z, well, here's an opportunity for you to stay part of our team through a 1099 relationship, so you don't have to go out to a locums company or go to another company. We wanted to provide opportunities for our providers to know that we want them here. This is their home, and we put various options on the table to allow them to do that.
Yeah, and I think that was really smart. I mean, the anesthesia market right now, we're seeing everywhere, not just in the Metro Atlanta and Georgia market, is a big want for 1099. Most people are going that locums route, and Piedmont and Steve and the rest of the leadership set up a viable offshoot that would allow people to be 1099s and still be there for Piedmont providing for their patients.
one of the things we did once it became public and we could speak, we approached it with as much transparency as possible. We set up town halls, we set up opportunities for our leaders to be out in the hospitals and answer questions real time. We didn't want them to hear, hey, we're making this change, and then they don't know what their future is. So we invested hundreds of hours to ensure that we had an opportunity to meet them face to face, for us to be able to look into our eyes and see that we were 100% committed to this transition and to them, and that we wanted them to be part of this family and part of this program. So transparency, I would say, was a big factor. You know, emails going out from me and others to ensure that they understood where we were throughout the process, and really listening to them and following up if they had a question. We made sure that if we didn't have the answer then, they got an answer within a timely period of time. So just the transparency piece was key to this as well.
Well, I'm going to pile on there, Steve, and I'm not going to say it just because you're on the line with us, but I've got to say the senior leadership at Piedmont being as involved in this as you all were was really another key to success. And I think it shows in that 98% retention rate that you had. I mean, I remember being the spring or the winter of last year, and we were at one of your largest facility at 6:30 a.m. in front of a bunch of anesthesia providers just to sit there and talk and answer questions. You know, one of the biggest mistakes I think organizations make when they're considering or doing these transitions is that lack of transparency and lack of communication plan, because the rumor mill spins up really quick. And before you know it, there's a lot of false narratives that are going around that are causing people to look for other opportunities. And they just didn't do that there. They probably looked, but kept them in the loop. There wasn't a lot of negativity. Someone was always available. You had weekly updates that were being read. You had leaders that you identified that you could speak to and hear from the group, understand what's going on, and it was addressed quickly, which I think was superb.
And that's not saying we didn't have naysayers. And so you're always going to have that 10%. And so we really aggressively manage that 10% as well, and to make sure we put the energy into that 10% to show them that we wanted them to be part of this as well. We lost a few people, but you know, at the end of the day, that may not have been a bad thing, but we were able to, you know, just again, to retain 98% was incredible.
Well, you know, I tell a lot of clients retention of 100% isn't necessarily a good thing.
Yeah, exactly.
From a business standpoint, it means you're probably over-promising something in that compensation package.
Yeah. So we're going through two phases. One, with some of the providers that came over, we assumed their existing contract and it was assigned to us. And so we're now finishing a process to convert everybody to Piedmont paper and our standardized compensation model that we're now utilizing across all of our employed sites. So part of the tangible is just around that. We have a better way of measuring performance, tying dollars to the work effort. You know, the comp may have gone up a little, but at the end of the day, it's saving us money in terms of the way it was being managed before. Some things that we found in certain situations that, all right, we're paying people for services possibly not being provided. And so we've been able to eliminate some of the waste there. I think too, as we've now are more stabilized, we're able to sell to future or potential employee. I don't even like to call them employees, anesthesia partners. Hey, with this, you can come in and have a career. If you want to come in early in your career and work in a very advanced hospital, we have that for you. As you move further in your life cycle and now you have a family and kids and want to move out to a rural area, we have, or an urban area, we have hospitals there that match your lifestyle. We have ASCs. And so now we have something to really recruit into that will allow us to move away from the locums the number of locums that we have in the system or contracted providers we have in the system. So we're starting to see some of that change where people who were contract to us are now migrating to either our 1099 program or coming back to us as W-2s. So the savings opportunity associated with that is very dramatic when you look at the scale and size of our system. And I think what's also happening is that other groups that are in the market that support our hospitals are seeing what is occurring, and they're hearing positive things from the providers who have gone through this. And so we now have groups that, may be a little unstable in their market, and maybe they're smaller groups or whatever, who are reaching out to us and saying, hey, we'd rather be part of you versus selling to another national firm or something along that line. So we're seeing a lot of positive indicators. It's still fairly early for us. I mean, we made this transition May 1. So there's been a lot that has occurred between May 1 and now, and we're about to bring on another hospital on November 1, and we got 2 others lined up. So that's some of the positive outcome that we're seeing by offering the providers in our hospitals a stable, consistent program to join, where they don't have to wonder, hey, are we going to have our contract with the hospital renewed this contract term? Are they going to go out to market? Are they going to try to bring someone else in? There's a lot of positivity, and that's associated with what we have done.
Yeah, I completely agree with that. I just wanted to go in a slightly different direction that I've seen over the last few months that maybe isn't as quantifiable, but there's a qualitative component to it. Having anesthesia under a larger portion of anesthesia under employment, especially at your larger hospitals, getting that data, understanding the hows, whys, whens of anesthesia, why the costs are X, Y, and Z, what can we do to bend that curve a little bit, and understanding then going to those hospitals and explaining to them and kind of teaching them, kind of going back to what you were saying earlier, Steve, allowing that anesthesia service to almost be a reason to engage some of the hospitals and leaders in understanding how they can run the ORs a little better. I think those are conversations that's stemming a little bit out of this that is also going to have a large impact.
Very much so. And that's part of what we said about the educational piece and making sure they understand how the entire book of business works and how they are reliant on one another.
Go ahead.
I said the other thing too, when we look at the value proposition, and I touched on it a little earlier, we probably focus more on stabilization versus cost reduction. And when you look at, if you have an unstable anesthesia network or provider group, or it's going to end up costing you a heck of a lot more. Are you having to close ORs? Are you being forced to reduce services? If someone were to just say, we're no longer working in your hospital, we're terminating your contract, I mean, that's 50-some% of your hospital's revenue that it completely gets disrupted. So we focused on stability first, optimization second, and this is all within the whole context of we wanted to create a great work environment that people wanted to be part of and want to be part of a culture. Stabilization, opportunities for efficiency, which will then drive the cost equation, and then just the opportunity for growth and development. And how do we bring people in, grow them, and give them an opportunity to really have a very complex career with all types of anesthesia sites and services that they could participate in, from very large complex transplant hospitals to all the way down to ASCs.
Yeah. It's kind of a, if you build it, they will come scenario, right? I mean, and as you said that, I don't know what the latest numbers are, but I believe the cost of locums and premium pay has been slightly decreasing as we've gone through this. And I think it's just a reflection of the culture, a place people want to work, and, transparency and leadership that we talked about.
I mean, before it was primarily through a middleman, now it's direct. And I think that's one of the things that the providers were shocked about when when we were able to start talking to them in person, that, they didn't realize that, well, what do you mean no one told you we were needing X, Y, and Z? Or no one told you about our issues or concerns here. It was, our relationship was through a middle person, basically whoever ran the various groups that have become part of Piedmont. And so the frontline providers were assuming that we weren't just listening. And many times they've realized no one was telling us. And I think that has helped dramatically. I mean, I get emails directly. I open up, here's my email address. Here, feels like most of them have my phone number based on the number of phone calls and text messages I've received too. So, but that's part of it. That's part of transparency, and, being, giving them the ability to know that people are listening.
Yeah, and I think you got even a little more granular, and I don't want to give too many details about or specifics, but there were stipends that were approved by Piedmont that never got, or potentially didn't get passed down to some of the providers. And I think those were some instances where there was some trust that was lacking, and some miscommunication that I think was alleviated through the transition to employment.
And again, we're not talking about any one group out there. We've got many groups that have come into Piedmont. And so, but there are some commonalities in all those groups, and that was a gap, a perception that we were just not listening. And we've been able to, I think, eliminate most of that thought. Again, not everybody is 100% on board yet with, I think there's still an area of, all right, this is nice. Before you get all my trust, I need to see a few more months of this.
It was an absolutely wonderful client to work with. Leadership was fantastic. And like I said before, it was a huge key to the success in this, frankly, very risk-heavy decision that was made.
Yeah. And again, I think it is, what I'd say is, if you're contemplating doing it, it can be done. It can be done successfully. It's scary to jump into it because of the potential disruption, but I don't think the anesthesia market as is going to get any better. So I find it, and we found it much better to say we're in control of it, and we're controlling our destiny versus third parties controlling our destiny. I think too, Jason, I'd like your thoughts briefly on this as well, is what really also made it successful is this was something that was supported from the board level of this company all the way down. Our CEO, Kevin Brown, the executive vice president for the system, who was my partner and who I reported to with this, Michael Mandel. Once we said do it, they threw all the resources to make sure it was successful. So it had to be done as a system, and the fact that the board, the CEO, the executive vice president were completely behind it. And once we said we're doing it, it made it much more seamless. And I don't think we would have been successful if we didn't have that level of support throughout the top levels of the organization.
I completely agree. I knew we'd be successful when early on we asked about goals, and it was you and some of the other leaders from there. And your major goals very clear, and made it clear that it was supported from high levels within Piedmont. And I knew that with the transparency, the goals being agreed upon, that we could do this successfully with their support.
And for me, it really came out when the board and Kevin Brown, the CEO, we had what was called a plan on the page, which is our strategic priority for the next year. Anesthesia was listed as the #1 strategic priority for the system to ensure its success and to ensure that we were stabilizing anesthesia. So that rallied the whole system around making it successful as well.
And to be honest with you, in order to make these things successful, there has to be the ability to pivot, change course at times, take different tactics. And at all time, and in no time during this engagement did I ever feel as though there weren't ears to be receptive to some of the concerns we had as a consulting company, or you had on your end, that weren't listened to and reacted to fairly quickly. And that was also a huge factor in the success.